Welcome, everyone. It's a pleasure to have you all today. Dr. Davis is joining us today from Maple Valley. She'll be talking about Botox intervention for dystonia care. I'd like to introduce Dr. Davis. Dr. Davis is a board certified neurologist with subspecialty expertise in movement disorder. She specializes in diagnosis and treatment of tremor, cervical dystonia, hemifacial spasm, blepharospasm, and other movement disorder conditions. She is a fellowship trained movement disorder neurologist with expertise in Botox injection and DBS. She's highly skilled in Botox injection for spasticity, dystonia, spasm, and migraine, as well as DBS patient selection and programming for Parkinson's disease, tremor, and dystonia. Welcome, Dr. Davis. It's a pleasure to have you today.
Thank you so much for having me. I appreciate your time today, and I'd love to talk to you about this topic. It's something I think you can make a really big difference in when you know kind of how to diagnose and how to manage. So I'm going to go through a few slides, and then I'll leave some time at the end to go through some Q&A. Let me see if technology is going to be my friend today. Let's see. Nope. Let me go back to the beginning. Can you see my slides okay?
Yeah, all good.
Okay, great. All right, so as she introduced, my name is Dr. Davis. I'm an osteopathic doctor and a board certified neurologist with movement disorder subspecialty training. I practice in my own clinical practice in Maple Valley, Washington. We are open and accepting new patients, so anybody who's interested, we would love to see you. So kind of go through the basics first. So what is cervical dystonia? So it's a focal dystonia, meaning it affects one area of the body involving the neck. Sometimes that can extend into the shoulders, but it's predominantly focused just in the neck muscles. It causes an abnormal twisting, tilted, and sometimes tremulous, which means a shaky type of movement involving the neck muscles. And there's an abnormal balance between the agonist muscles, meaning the muscles that are trying to do that particular movement, and the opposing muscles, or the antagonists that do the opposite movement. And that imbalance results in either twisting, tilting, or combination of features. That is what we are able to diagnose clinically when we do a good exam. And addressing those types of abnormal postures and patterns is what allows us to relieve the symptoms. Most patients with cervical dystonia have some element of pain. So in different studies, up to 90% of patients experience pain as part of their condition. It's a very common, actually the most common focal dystonia. So about 30 people in 100,000 will have this condition. And about 3/4 will have some sort of sensory trick. And that's a very characteristic feature of this condition. And what I mean by that is basically in cervical dystonia, sometimes there's an area of your face or head that you can kind of lightly touch, or even think about touching that area to get some temporary relief in the direction of pulling. So for some patients, that's kind of lightly touching their chin or putting their back of their head against something. And that just that sensory input can help to stop the pulling. So why does this happen? It's a very complex and not fully understood process, but it involves the brain. So basically there's an improper processing of information. So proprioception is the sense that our body integrates vision, hearing, and touch in order to help our bodies understand where we are in space. Where we are, kind of, are we turning our head left? Where are we in relation to other things in our environment? And this process normally kind of goes through the brain. The thalamus, which is a deep structure in the brain, integrates that information, sends signals to the motor cortex, which initiates movement. And we have this well-coordinated, kind of balanced movement, just the right amount of movement to achieve our targeted goal. But in cervical dystonia, there's a few areas of dysfunction. One of them is that the thalamus is not appropriately regulating the amount of information that's going to the cortex. So it's letting a bunch of extra information coming in through that proprioceptive pathway get through. So instead of just sensing a little bit of something in our environment, it's giving us a lot of extra sensation that leads to excessive movements or corrective movements through the basal ganglia. So it's a really complex pathway But there's basically some changes that allow people to be more susceptible to developing these abnormal movements that often exist for many years before we actually see the symptoms. And it's this pathway where we're able to kind of modulate the output, the downstream effect in terms of the movements with botulinum toxin or Botox. So most of the cases are primary cervical dystonia, which means, and most of those are idiopathic, which kind of means we doctors are idiots. We don't fully understand why this happens. So most of the time we don't know a cause. There are some genetic forms of cervical dystonia. I listed a couple of the known genes that we have. Some patients will have a family history of other types of movement disorders, suggesting that there's some genetic susceptibility to this. So some patients may have family members that just have a tremor that involves the hands, like essential tremor, may not have dystonia, but there's similar pathways in the brain that are involved in both conditions. So it may look different in different family members, but there's a susceptibility there through the family. Parkinson's disease and other forms of dystonia that might affect other portions of the body. So most of the time, the cervical dystonia will stay isolated in the neck, but other family members could have different kinds of movement disorders. In some patients with cervical dystonia, there's a post-traumatic component. So after like a whiplash injury, head injury, something else basically kind of sets off that process or exacerbates those abnormal movements. All of those still fall under that primary cervical dystonia. And then sometimes there's a secondary cause, and that could be medication. There's certain psychiatric medications that can cause a dystonia. Typically, those are a retrocollis, where your head is pulled really far back. Other times, a stroke in just the right area, either in that thalamus that I showed on the previous screen or the basal ganglia, can cause a dystonia. And carbon monoxide poisoning also can give you a cervical dystonia. So cervical dystonia is basically diagnosed by the physical exam. And this is where you really benefit from seeing a movement disorder neurologist who's trained to recognize the patterns and the subtleties of movement, because understanding the pattern is how we appropriately treat and get good response when we use botulinum toxin. So we describe the pattern of movements based on the ease of movement. So what we will have a patient do, first we just sit in front of them and look at the primary position of the head. And usually what I'm looking for is what direction is the chin. So if the chin is slightly turned to the left, we can usually see the right ear a little bit more prominently, and the chin is off midline. I would then have patients kind of turn their head through the full range of motion. So turning to the left, turning to the right. The direction where it's easier to turn would be called that direction. So a left, if it's easier to turn the head to the left, the chin slightly to the left of midline, we would call that a left torticollis. Torticollis just means turning. We also look at the tilted posture. So if it's easier for the head to bend to the right, then we would call that a right lateracollis. Backwards is a retrocollis and forward is anterocollis. And most patients have a combination of these movements, which means that the pattern of injections to get good relief needs to be somewhat complex to be able to address each of these postures. I don't think that the video audio is going to play on this, but I'll kind of describe. This is basically a patient. It's a bit of an old video, but it's an exam kind of showing that exam that we do. So she's describing that her head wants to pull and turn to the right. So she's attempting to look straight ahead at the camera, and her head is constantly pulling to the right. So we would call this a right torticollis. She's attempting to kind of straighten her neck, and it constantly is wanting to pull right. Let's see if it's going to show us any of the other parts here. We typically will then do kind of a distracting maneuver of holding the arms up. We may have people open and close their hands as they're doing something else with their body. Sometimes the degree of movement will intensify. You can see in this patient, this muscle on the sternocleidomastoid muscle is quite prominent. So those are one of the primary muscles that move the head. She can fully turn to the opposite side, but when she tries to just sit in a neutral position, it continually wants to pull right. So let's do a quiz. Remember the movements are described as torticollis, so which way the head is turned. Could you guys guess kind of which direction this head is turned? This person's? So this is her left side. So the chin is slightly turned to the right. So we would label this as a right torticollis. The head is tilted to the left. So that would be a left lateracollis. Her shoulder is also elevated on this left side. So it's the muscles are kind of pulling the shoulder up as well as the neck to the side. It's hard to tell from this angle, but her head is pulled forward as well. So there's a bit of an anterocollis. Interestingly, this patient has a lot of pain had a lot of pain on the left side of her neck. So previously a provider had really just injected that left side, but didn't get very good results because there's this really prominent component where it's turned to the right. So without addressing that right side of the neck that's turning the head, we couldn't alleviate her pain. So once we added in injections to try to adjust both the turning and tilting component, the pain went away and she had much better range of movement. So really that comes down to basically the exam is really key in being able to appropriately treat this condition. So you need to be able to, your provider needs to be able to recognize those patterns of movement to be able to appropriately select the muscles that are going to give you the relief. So primary first line treatment is considered botulinum toxin, and there's several different brands that I'll speak about in a moment. There's basically Botox, Xeomin, Dysport, Myoblock, and now we have a new one called Daxxify. They all are approved for cervical dystonia and all can achieve great results. Older medications were anticholinergics like trihexyphenidyl. None of these were older pill medications were really approved for dystonia. We just found that using them, sometimes we got some degree of relief. But often it was a lot of side effects. So really sedating, sometimes cognitive fog or memory issues. So the pill options, because it's not a focal treatment, it affects the whole body. We end up with usually more side effects than benefits. So a targeted treatment like botulinum toxin, where we basically inject a medication into the muscles that directly relaxes them in that area without spreading to the rest of the body, helps us to achieve much better results, and we don't get those systemic effects like sedation. So botulinum toxin is considered first line, and then combining that with physical therapy, somebody who specializes in cervical dystonia can be really helpful. And in particular, trying to kind of retrain the brain with that sensory input. So as I mentioned, it's kind of an impaired integration of information from our environment, leading to abnormal twisted or tilted neck postures. So when we were able to block that reaction or that signal coming from the brain, transmitting to the muscles by using botulinum toxin, that helps to alleviate the movement. And then if we can combine that with somebody who knows how to do physical therapy for cervical dystonia, we can kind of reshape those pathways in the brain, allowing them to have more normal movement over time. And that combined approach can be quite helpful. So one question I've heard a lot is, what's the difference between a provider who maybe injects without EMG guidance versus one with EMG guidance? And it really depends on how you were trained. So I definitely can see, pretty equal results in some providers who don't use EMG and those that do. It really depends on how you were trained. I use EMG in my practice. I think there's some benefits to it. I find that I can use lower doses of medication than providers that don't use EMG, because it allows you to be more guided, specifically targeted to the muscles. Another advantage I see with EMG is that actually the volume of the sound that we get from the muscle activation, so that spontaneous muscle activity that's causing that tightening and pulling, when we hear the degree of sound, so if it's very loud, we know it's a very active muscle that has more of that dystonia present, meaning it's more of a contributor to that posture. That helps me to guide the dosing. So if it's a very severely affected muscle and it's part of that primary kind of posture, then I may want to use a higher dose in that particular muscle based on the severity of that EMG sound. So in my practice, I feel like EMG is very critical to the success of what I do. But I know there's many providers who are just very skilled, localization, palpating the muscles, looking at the postures. They can still achieve very good results without EMG. So it really is injector dependent. So if you've got great results with your provider and they don't use EMG, no reason to change. But if you're not getting adequate results, maybe worth considering a movement disorder neurologist and maybe somebody who uses that EMG guidance for improved localization. So basically, let's talk about botulinum toxin. So basically, there's communication. The brain sends the signal down through nerves. Nerves, basically, when they want to trigger muscle contraction, they release acetylcholine. The way that botulinum toxin works is it blocks the release of that acetylcholine so that the nerve signal, it's still coming from the brain telling the muscle to contract. That dystonic signal is still getting down through the nerve. But when we use botulinum toxin, we're able to block some of the release of that acetylcholine so that less signals getting through to the muscle to contract. It's not complete. There's just a reduction in the amount that's getting through. And so with that, we get some reduction in strength, but what that translates to into somebody who has a lot of excessive movement from the dystonia is just a reduction in that excess tone, but the goal is still to maintain strength, just reduce the excessive dystonic tone. So it typically takes about 7 to 14 days for any of these botulinum toxins to take effect. So you don't want to go into it expecting immediate results the same day. I find some patients do get some immediate relief. It's almost like an acupuncture effect. The needle just going into the tight muscle triggers some temporary relaxation. So you may feel actually some relief the day of the injections, but that wears off pretty quickly. And then it's about 7 to 14 days for the botulinum toxin to kind of do its work in that nerve, blocking that release of those acetylcholine transmitters. Peak effect is typically around 1 month. So in my practice, I like to have patients come back in about a month to assess the degree of improvement, maybe which areas still were a little bit undertreated, if we ran into any side effects like some neck weakness. And then we use that information at that peak effect to guide our adjustments for the next injections. Typically only need to do that the first couple times after we're establishing a treatment plan. Once it's been established, it's kind of like a prescription. Just every 3 months, come back, repeat the injections, and achieve that same result. But it does take, when we're a new start and you've never had the treatment before, it typically takes 2 to 3 times. And usually most of the toxins are spaced out about 3 months apart, some a bit longer. But it takes 2 to 3 sessions where we're kind of fine tuning the dosing to get the best results for your body. But typically at that point, it is a pretty standard prescription, maybe slight adjustments over time. Some patients will have some extra spasm in the muscles the day of the injection. You can imagine sticking a needle into a muscle that's already tight, sometimes makes it a bit angry, kind of extra spasm that day. Sometimes we'll use some medicine like a muscle relaxer just to combat that immediate spasm. But usually most folks feel like it's not too bad. It is an injection, so always risk of bleeding, bruising, but typically that's pretty minimal. The bigger side effects that we can see are local weakness, and usually that's an issue of dosing and muscle selection. So typically, if there's going to be weakness, it might be neck extensor weakness, which means when you try to bend down, it's kind of harder to pull your head up, though sometimes it can be a little more difficulty turning. That's where it's really helpful to do that recheck when the injections are at their peak effect, so we can take that information and then make adjustments to avoid that in the future. The good thing about these treatments, and the bad thing, I suppose, is that it's temporary. So if there's any side effects, they do wear off, so nothing's permanent. But the downside is the benefits also wear off. So they typically everything's going to be with Botox, CMN. Those are typically going to be fully worn off by 3 months. So that's the good thing. There's nothing going to be permanent from it. More rarely, we can see swallowing issues. Typically, I find that's a placement issue. So if we're injecting really anterior neck muscles towards the throat, so someone who has that anterior collis where they're pulled forward, injecting in the center too deeply and in the too far anteriorly can sometimes trigger swallowing issues. I don't see that in my typical placement where it's further back in the neck or the lateral neck, but it's a possibility. So this is that same patient with the really significant right torticollis, left lateral collis. she was struggling to turn her head to check her mirrors when she was driving. This is after 2 rounds of botulinum toxin. So it's not perfect, but significantly better in that midline position. So she's much more straight. Her shoulder and neck, they're not as tilted to the left. This is a static photo, so you can't appreciate the improvement in her range, but she was able to check her mirrors when driving. Pain was improved, really quite happy with the results. When she came the first time to see a neurologist, she didn't know that anything could be done for this. So she was just really happy after we were able to achieve that result. So we have lots of different options available for forms of botulinum toxin. There are different brands. So Botox is the oldest brand, so it's been out and approved for this indication since 2000. So most practices, a lot of times that is the initial thing that's tried, and it works quite well. Typically lasts about 12 weeks, but for some folks, they really don't get that long of a duration of benefit, maybe 8 to 10 weeks at the most, kind of wearing off towards the end with return of those symptoms. And it has some proteins that are attached to the botulinum toxin. So in some patients, they start to develop some antibodies that neutralize the benefits. And so that can be seen as just complete lack of effect, or just the duration of benefit getting shorter and shorter over time. So Xeomin has very comparable effects to Botox. There's no direct conversion from one of these medicines to another in terms of dosing. So there's always some fine tuning and adjustment. But Xeomin's pretty close to one-to-one to dosing to Botox. It doesn't have that protein, so we don't see patients developing that resistance over time. So that can be a nice option if we do see patients that are kind of losing some of that effect from Botox. Switching to this can be helpful. Dysport has also been out for quite a while. This one has a little bit longer duration of benefit, so up to 14 weeks with this one. The dosing is quite different from Botox and Xeomin, so it's a great option if your provider is very familiar with this toxin and used to the dosing. In my practice, it's kind of challenging to switch between the two from Botox and Xeomin, which are very similar in dosing, to this, which has just totally different units. But for some folks, again, that are kind of having waning effect from the others, this can be an option. Maya Block also has quite different dosing from Botox, Xeomin, and Dysport, but this is another one that gives a little bit longer duration of benefit in some patients, up to 16 weeks. All of these are FDA approved for cervical dystonia and have good data in terms of efficacy. There's not really been any head-to-head studies where we've compared one toxin to another to see that one is superior. They just compare it to placebo and they see it's much better than patients who go without treatment. And then the newest one to the party, so this was approved, I think, at the end of last year, but only just available like in the last week to actually order. So Daxxify, or daxibotulinum toxin, is a toxin A, so similar to Botox and Xeomin. But the nice thing is it actually has a little bit stronger affinity for kind of blocking those receptors. So we get a longer duration of benefit. So patients had in the clinical trials up to 19 weeks and sometimes as long as 26 weeks of benefit. So this is showing this open trial where they basically, when patients felt like they had about 50% reduction in symptoms, they could ask to get retreated. So most patients, or all patients, were able to basically go the full 12 weeks without wearing off. So we weren't seeing symptoms return at 8 or 10 weeks. It was lasting the full 12. And then some patients, so this is the percentage of patients that were able to go longer. So about 26% could go as far as 16 to 18 weeks. And then 10% of patients, it really lasted a long time, and they could go as far as 26 weeks without needing to be retreated. So this is our longest acting one that's now available for patients. I like the idea of long acting in somebody who's really stable on like Botox or Xeomin, or one of basically Botox or Xeomin. If they're very stable but they're wearing off, but we've got the pattern really defined in terms of which muscles are involved, kind of the dosing. This is also close to one-to-one with Botox and Xeomin in terms of dosing, though not exactly, but pretty close. So if you're really stable but just wearing off too soon, kind of making that transition to Daxxify could be a really good option, because we can get that nice sustained benefit. at the least, that solid 12 weeks of benefit without wearing off before, but potentially, 4, 5, 6 months in some patients. I'm a little hesitant maybe to start somebody newly with this who's never had exposure to others, because just like the long duration of benefit, there could be really long duration of side effects as well. So if we did end up with weakness, potentially that weakness could extend for many months as well. So pros and cons, but I think the idea of less frequent injections is super appealing for a lot of people. So this could be a really exciting option. It's also about half the cost of Botox and the other toxins. So coming in kind of disrupting the market with some advantages in terms of cost as well as the longer benefit. So just kind of quick takeaway points, and then I'll open it to question. So again, cervical dystonia, it's diagnosed clinically. So it's the physical exam that gives us that diagnosis. I didn't mention, but sometimes we will do an MRI just to rule out other causes. Like I mentioned, sometimes stroke or other things can cause dystonia. But most of the time, we're basically taking the good history. If it matches without any other external signs or symptoms, it's just isolated to the neck. We're thinking it's classic cervical dystonia. And that exam guides which muscles are involved, causing that posture. It's quite treatable. Botulinum toxins are first line option and should be considered in patients with this diagnosis. And again, picking the right muscles is the key to success. I think that's the benefit of a movement disorder neurologist. They're used to noticing those particular subtleties of the patterns that really leads to good outcomes. And then benefits of botulinum toxin: reduced pain, improved movement, reduced tremor in the neck, and just better quality of life. And then that additional component of physical therapy with botulinum toxin really does optimize the outcomes, and it's a good thing to consider. Any questions? Thank you for your time.